Okay, ladies and gentlemen, I see very well the presentation, and welcome at the scheduling seminar. And let me ask Mike Pinedo to introduce the speaker.
Okay, let me introduce Mike Carter. As you can see, Mike Carter is from the University of Toronto in the engineering school. And he is one of the authorities of scheduling in healthcare. As you know, the Canadian healthcare system is one of the best organized healthcare systems in the world, if not the very best. And since scheduling is such an important part of the effectiveness of a good healthcare system, lots of the quality of the healthcare system of Canada actually is due to Mike Carter. And he is going to tell us about all the open problems that still exist in healthcare. So if there are PhD students among the audience, you may get some ideas about areas of research or thesis topics that you can. Okay, let me give the word to Mike Carter.
Okay, thank you, Mike. Unfortunately, I have, as I usually do, I have more slides than I'll get through. I'm happy to take questions at the end. My adventure in healthcare. This is open mic night at the hospital. One of my friends, Irving Hans from the Netherlands, sent me this cartoon, and I'll tell you, some days I feel like that. I'm not sure that doctors are always thrilled to hear the message that I've got. So I finished my PhD in 1980, and I was mostly doing scheduling, timetabling, nurse scheduling problems. Most of my research in the 80s was in scheduling. And then in 1990, I got involved with an operating room scheduling project with 5 large academic hospitals. The project went over about 2 or 3 years, and I realized how bad things were. You know, like just to give you an example, today the fax machine is still the major form of communication in hospitals and doctors, and they can't get rid of it. Fax machines don't exist anywhere. Anyway, I say healthcare is 30 years behind other industries, and that's probably generous. And 30 years ago, nobody was doing anything from a process or efficiency or a system perspective. And I decided I wanted to change that. So I spent 31 years trying to convince engineers that they should work in healthcare, and then trying to convince healthcare that they needed engineers. And it was not this was the kind of struggle. I have my main claim to fame is I have 150 former students who now work in healthcare in Toronto that I know about. So most of the hospitals have 2 or 3 of my former students, the network of contacts. And I started working originally on operational scheduling problems because that was my background. And I've expanded into policy and system level problems, information technology, quantitative problems, and some qualitative issues too. But my general focus has been on operations research and management science. So the outline, I'm going to go through 7 different problem areas, and I'm going to touch on them briefly. And what I'm looking for is for each one of them, for this audience, I wanted to point out sort of what the structure, the basic structure of the problem is, and why it's a challenging problem, and what are the potential opportunities, and also come up with for each one, I've come up with some examples of some issues. So we start with nurse scheduling. They're one of the most common ones, and one of the most, Mike had just asked me last night around 8 o'clock if I could supply a list of references for each one of these. I will supply that later on today, and it will get posted. So there's a lot of different problems. Nurse scheduling. So nurse scheduling, the basic issue is, it's 7 days a week for hospitals, 24 hours a day. It's either two or 3 shifts per day. It's either 2 12-hour shifts or 3 8-hour shifts, 40 hours per week average. And how do you manage to cover that? So some of the scheduling challenges, well, first of all, there's complex union rules. So for example, the union requires weekends off. Every nurse must have 1 out of every 2 weekends off. There's shift change restrictions. To change shifts, you have to have 24 hours off between shift changes. The schedule is typically produced 6 weeks in advance. You have to tell people when they're going to be working 6 weeks before they start. So the schedule posted today on June 28th is going to cover August 9th to September 19th. So we have to forecast the demand for August 9th to September 19th, 6 to 12 weeks in advance, to understand what the patient demand is. And that's what we schedule our nurses to meet. So we have no idea who the patients are or what their illnesses are, what their issues are. The nurses have preferences. Everybody wants to work day shifts on the weekdays, Monday to Friday. There's seniority, there's all kinds of issues. Right? Patient complexity varies widely. So the workload is actually much higher on when the initial days of patients are, after surgery. The first day after surgery, there's very high workload. The last day before they're discharged, the workload's very low. So the balance of patients, how do you do that? How do you manage nurses? And then the other issue is handoffs. It was funny when I started this way back in the 1980s. Nurses used to work an 8.5-hour day, and the half hour was for the overlap to the next shift, so they could tell the next nurse what was going on. And in Ontario and most places, that 8.5 hours was changed to 8-hour days. So for most hospitals, there is no overlap between shifts. So nurses have to leave notes or they leave messages. They spend the last half hour of their shift not looking after patients, but trying to leave enough information for the handoff. Handoffs are actually a huge medical error, a huge medical issue. So there's a lot of challenges with nurse scheduling. There's been a lot of work on it. There's commercial software to do it, etc. Some of the potential solutions that people have come up with, pardon me, as I flip down, looking at my notes here. There's, column generation so that, typically, sorry? Oh. Column generation so we construct feasible shift patterns. Typically we'll construct patterns that are 80 hours over 2 weeks. 40 hours over 1 week doesn't work very well. And then out of those patterns, then we have to select how many nurses work each one of the patterns so that we cover all of the demand. Another approach is to construct cyclic shift rotation patterns. So some sense of equity. So a nurse would rotate over 8 or 12 weeks, rotate through a number of different shift patterns, and then when they got to the back, they'd come back to the beginning and start over. And so then you'd put together these blocks, and each one of them to try to get, because, how many people are working nights? How many people are working days? You want to have some kind of equity around that. And typically with nurse scheduling, what we do is we have the union rules will say we need a fixed number of the nurses need to be full-time. So they will sort of do the base scheduling, and then we can fill the gaps with part-time staff. So there's a lot of software available, a lot of solutions available. I just wanted to highlight, here was an example that came up last year. And there was it's not nurses, but it's a similar issue. Mental health support call center in a small area in the outskirts of Toronto. And so as a mental health support, and they were working Monday to Friday, 5 days a week. And the staff decided it would really be nice to go to a 4-day work week instead of a 5-day work week. And the management decided that would be just a great idea. And by the way, if we're going to go to a 4-day work week, we should have a call center. This mental health call center. We should have evenings. We should have Saturdays. We should do a bunch of things. Now the staff was thinking they would work either Monday to Thursday or they would work Tuesday to Friday. but somebody has to get off Wednesday and Thursday. So somebody has to have a Monday, Tuesday, Friday, Saturday shift. That's completely unacceptable. So you imagine the possible shift rotations that would be required. You know, I mean, one way that would actually work well from a scheduling perspective is having a 3-day work week, and 13-hour days or something that might work. So people would either work the first half or the second half of the week. And the problem got even worse because they actually had a whole pile of different specialists working in different areas. And some departments had only 3 people. How do you do a rotation for that? And some people had 10 or 12. So the number of staff they had influenced the way the patterns could go. So it was a fascinating problem. It seemed like a really simple idea and a really easy idea and a small problem, but it turned into just a huge headache for them. We gave them some ideas. I'm not sure what they did with it. You know, one of my problems is a lot of the problems we work on, we give them a solution and they go away and think about it. And I never do follow up and find out what happened. Okay. Nurse planning. So nurse planning is it's sort of the tactical planning idea as opposed to the operational level. And nurse planning, what's the workforce hiring problem. So how many nurses do we need to hire? How many nurses do you need in each one of the hospital units in the future? Right? And planning for the next, typically for the next, 6 months to a year. In Ontario, and most places have similar levels. We have registered nurses who take a 4-year university course. Registered practical nurses take a 2-year college degree. Nurse practitioners, after they do their RN, they do a master's degree, and it's called nurse practitioner, and they're allowed to prescribe. They have much broader specializations. And then, of course, each nurse, there's all kinds of certifications. People can be certified for critical care, for emergency departments, etc. The challenges in the scheduling, it's like the turnover rates, retirement, transfer, termination. And typically when a nurse leaves, most places they give 2 weeks notice. But it takes 2 months, at least 2 months, to hire a replacement. So typically, a unit will find out it's short and they'll put in a request. The request has to be approved. Do you really need that person? And then once it gets approved, then they'll advertise for it, try and hire somebody. And they're also limited for nurses by the hiring capacity by nursing school graduation cycles. It used to be that nurses would graduate in June in Ontario. And so in June, there was just a pile of nurses available looking for jobs. But by September, they'd either found a job or left the country. They've gone to the U.S. That's our brain drain. They go down, help Mike. And then absentee levels. So there are, how do you plan for covering shortages? And fair number of nurses actually have a very high level of sickness, of absentee situation. So it's a huge challenge. So how do you meet patient demand? You have to have enough nurses to look after patients. Okay. And how do you do that? So potential solutions for temporary staffing challenges. The main ways they look at it, the main way they cover, temporary absences. There are part-time nurses who can come in on fairly short notice. They may or may not be available. Some nurses will be happy to work overtime, work an extra shift. That's always a bit of a challenge. And the use of agency nurses. So there are agencies that will supply nurses for hospitals. One of the problems with agency nurses is that you bring in somebody who has actually never worked in that unit before. And so then one of your full-time nurses will spend half of the day training the agency person. So instead of losing one person, you lose 2. So for short-term, a day or 2, it's really not worth bringing in an agency nurse. If you're going to bring in somebody for a leave, somebody's on vacation, a couple of weeks or a month, that's different. That's not so bad. agency nurses, overtime, part-time nurses, they all cost more money too. Plus, somebody has to manage all this. So the nurse manager. So it's a tricky problem. A lot of hospitals over the last 15 years or so have gone for something in calling, well, they call it different things, but a nurse resource team. So it's a pool of nurses that are not assigned to any unit. And so this pool of nurses is just waiting on a daily basis for, if somebody calls in sick, well, we've got a nurse who can fill in. And because these nurses, the NRT, the nurse resource team, because they've been working at the hospital, so they have experience working in the hospital, working with the team. So they're not sort of brought in out of the blue. Okay. This is and with the NRT, the big question about the NRT is, how big is it? How many nurses do you have? And the hospitals typically don't actually know, they don't actually manage. Well, again, in the Canadian instance, they don't actually manage the relative costs. So they wind up, the NRT has a budget and each individual unit has a budget. And it's really difficult to discover, is it cheaper to have an idle, if you have too many NRT nurses on a particular day, then you're paying somebody who doesn't have anything to do. Versus when you're short, if you don't have enough NRT nurses, you're paying agency or overtime, so you're paying time and a half. Try to balance those things. I've got a project on right now with one of the hospitals looking at nurse planning and trying to predict how many people are going to leave in the next 3 months and trying to plan ahead. This is an example. Now, this one is not really, it's a planning problem. It's not really nurses, but it's a similar idea because it's 24/7. This was a problem we looked at several years ago with the Toronto ambulance, Toronto EMS. And so you see the little diagram in the upper right, and that shows the number of calls that are coming in per hour on average by day of week. And you see that the calls go from about an average overnight of about 15 or 16 per hour up to over 60 per hour in the peak times during the day in Toronto. And of course, this depends on the area. So what happens is when you call 911, the 911 operator, if they need an ambulance, gets directed to Toronto EMS, and they have call takers. And so the question is, how many call takers, how many people do you need answering phones? Now, you don't want to get a busy signal when you call 911. You don't want to have, say, please call back. We're experiencing a high call volume at the moment, the recorded message. And so the metric is that they want it to be answered on the first or the second ring. And in fact, the way Toronto EMS had this thing set up is that if it is not answered fairly quickly, what happens is every phone in the whole office goes off, including the chief. So somebody will pick it up if the call taker doesn't take it, right? And the problems with this thing, so they wanted to be answered, and the shift types, they're all 12-hour shifts, and because it's unionized, the shifts are all fixed. You can't play with them. So the shifts are 7 a.m. to 7 p.m., 7 p.m. to 7 a.m., 11 to 11, and 2 to 2. And those are the green slots. And so the question you have is how many people are working in each one of those slots, and you're trying to meet the demand, which is very time sensitive. So how many call takers do you have on each one of the shifts? And so they'd actually, before they called us, they actually used queuing theory to figure out, they wanted to be 90% sure they got the answer. And they did that. They figured out how many staff they had. What they didn't account for was that the union says these people in a 12-hour shift are allowed to take lunches and coffee breaks. Well, they don't want to go to coffee break by themselves. They want to go with their buddies. So 2 or 3 of them will go off and take coffee in the middle, right? Well, wait a minute. So in fact, the breaks have to be scheduled. The breaks have to be worked in. We worked on a couple of things with an Excel solution, a simulation model, and a queuing model. The third problem I wanted to talk about briefly is on chemotherapy scheduling. And chemotherapy, the chemotherapy process, it's basically people with cancer and typically blood cancer, and they inject you with very powerful drugs that sort of kill everything in their path. They kill the good cells and they kill the bad ones. They kill the cancer cells. And because of the physiology, it turns out that the healthy cells grow back faster than the cancer cells. So if you keep doing this repeatedly, you kill off all the cells. The good ones grow back, the cancer ones don't so much. And after quite a bit of time, you wind up killing off the cancer cells. And it's like a sledgehammer on a thumbtack, but that's sort of the state of the art. So what happens on the process for chemotherapy is, and I'm going to use an example of a hospital. I'll give the reference later. But a hospital we did, so they had 100 patients per day, and patients show up, and first thing they do is they get a blood test. Because you want to make sure that their healthy cells have recovered enough so that they're strong enough to take the chemotherapy. If you try to give somebody chemotherapy who hasn't recovered yet, you could kill them. So they wait for the lab results to come back before they decide to actually proceed. So you don't actually know if the patient is going to be coming in or not until you get the test back. That has to be reviewed by a physician. At that point, after the physician approves it, they then order the drugs from the on-site pharmacy. The drugs there's 350 different regimens that are required. So they don't premix any of the drugs, and the drugs don't last. And there are all kinds of formulas for how these are done for each different type of cancer, each different type of patient. So they don't mix anything. So now you have to wait for the pharmacy to mix the thing and set it up. Wait for the drugs, right? And then the patients are sent to get their chemotherapy in a bed or a chair, after everything's ready. And the chemotherapy itself, it might go for 1 hour, it might go for up to 8 hours. Depends on the regimen. And there were in this place, there were 13 to 15 nurses looking after 33 patients at a time. And the nurse, when they set a patient up at the beginning, it takes 10 to 20 minutes to get a patient set up. And then after that, you monitor them. You're just watching patients. So when you're monitoring them over the course of the 1 to 8 hours, one nurse can watch up to 4 patients. But one nurse can only set up one patient at a time. They can't watch anybody else while they're setting somebody up. And then at the end, it takes about 10 minutes to disconnect the patient, make sure they're okay, test their vital signs, etc., test the machine, make sure everything worked all right. And so that's again one-to-one. So how do you organize the patients? How do we organize the patients so that patients are booked? It's like a monster Tetris game, right? Because trying to put these into place. So patients are booked for a sequence of days, maybe 3 days a week for 4 weeks. Chemotherapy will actually go for 3 to 6 months. You'll go on for 2 or 3 weeks, and then you'll be off for 2 or 3 weeks, and then back again. And the scheduling is real time. And it would be great if we could do scheduling, if we could wait until the night before, until we knew which patients were coming in tomorrow, and then do our scheduling. But in fact, we have to book people. We're ready for the patients ready to be booked. It's a bit of an online system. It's a bit of a real-time system. So who gets booked on which day? When do they start? And when you start somebody, then they have to go. You're booking for them for 3 or 4 weeks at a time. So it's scheduling real time in batches. There are emergencies that show up. There are no-shows. There are cancellations on the day of treatment. They didn't pass the test. They didn't feel well. Have to do it again. It's a Tetris game. We also have to balance the nurses. So we're trying to maximize resource utilization, and we're trying to minimize patient wait time as they go through this system. So potential report, one of the solutions actually that's on the market commercially is you assign days to the patient, so you tell them what day they're coming in, but you don't actually do the plan the scheduling for the day until the night before. And then that gives them a start time. So you tell people the night before, okay, you come in at 10 o'clock, you come in at 12 o'clock, etc. Another thing that people have done is created a template. So they create the Tetris solution before we know what the patients are, based on how many 8-hour slots are we going to have, and how many 4-hour, and how many 3-hour slots, etc. And I went to one hospital, and they had created this template based on the historical data that they had for past patients. And I looked at their template, and I looked at their actual schedule that day, and there was virtually no comparison between the two. The actual schedule didn't match the template at all. And I said, what was wrong with this? What's going on? Well, it turns out that cancer therapy is a moving target. It's constantly changing. The patients that can be treated, the way they're treated, the types of patients you get, and the types of regimens are changing all the time. So by the time somebody had actually worked out a template, it was no longer valid. So we actually developed a dynamic template that actually changes as patients come through. We keep changing the template and then work on that. And as an example, the Sunnybrook Cancer Center, one of the ones that I've worked at a couple of times, it was just very difficult to arrange all the patients. You know, that how do you get the nurse? How can the nurses go home at 5 o'clock? And there was always, an 8-hour patient that didn't start until 3 o'clock, that was there until 7, 8 o'clock at night. And so there were always a few patients left over. It was really difficult, that make span problem, for getting everybody to finish at the right time. They have to start early enough. And because of all these delays and uncertainties, it was a difficult problem to do. Okay. Next problem that I wanted to talk about, I'm flying through things here. The next problem I want to talk about, surgical planning and scheduling. And so we've done a lot of work over the years with the master surgical scheduling process. And so the process works like this, that the hospitals allocate operating room time to surgeons. And typically they'll do this, they'll reorganize this every 6 months, but they have a regular schedule. So for example, Dr. Smith gets every Monday and Wednesday in OR number 4, and Dr. Smith has the whole day, long before Dr. Smith has patients. And what that means is that when you go to see Dr. Smith, the surgeon, in her office, she can tell you, okay, I've got time for you in 2 months. And so you pick a day, etc. And she can book patients into the future and knows that that OR is available. Most people work on this. It's called a block booking system, and most hospitals work on that system. In particular, the doctors are fee for service. Because they're fee for service, not salary. They're really not. They're not employees of the hospital. Okay? So they typically, and the hospitals actually typically allocate time to a service. So they'll allocate OR time to orthopedic surgery. And then the orthopedic surgeons will all get together and figure out who gets which day and how much time they get, etc. The hospital often can't even control who does when, right? Or who does how much. And one of the reasons for that is that if a hospital decided to cut the time of a particular doctor to reduce the time, they would find themselves in court, because this is the doctor's salary. This is what they're cutting into their earnings. So if somebody told me I was going to take a 10% cut in my salary, I'd be very upset. Right? So they get around this by just doing it, let the docs fight about it. Right? So they give up control. So they're trying to allocate time to the service, and then the docs are dividing it among the service. And they're doing this 6 months in advance. So they have no idea what patients, we're not talking about specific patients. This is a planning problem. So this is the master surgical scheduling process. Right? The surgeons will then book them in their own office. They'll book patients ahead of time, and then 1 or 2 weeks ahead of time, they will send a list to the hospital and say, okay, here is a list of patients that I booked to come in on such and such a day, and then the hospital will interact with the patients. This, as I said, the surgeons are fee for service; they're not salary. Okay. Some of the challenges. So when we're deciding, which doc goes on which day, we're trying to balance the use of downstream resources, recovery rooms and ward beds and nurses, etc. One of the things that when we were doing this problem, one of the things that we discover that operating rooms operate typically Monday to Friday during the day. That's when most surgeries occur. There's emergencies that happen in evenings and weekends, but the bulk of them happen during weekdays. And so what happens is the beds in every hospital I've gone to, the beds start to fill up by Thursday and Friday, and by Monday, the surgical beds are half empty. And it's a poor use of resources. Now, some docs are doing day surgery, and some docs are doing patients that are going to be there for a long time. So by adjusting who gets which day, by moving people around, they can do the same number of patients, but we can have a lot better control over recovery room, ward beds, and nurses. It's a political problem too, because surgeons have other priorities, clinics, teaching, research. I mean, I can't tell you how many times I've had doctors say, well, I can't do OR on Thursday because I have clinic that day. But then when I was trying to do clinic scheduling, I can't do clinic on Tuesday because I've got OR that day. Wait a minute. So it becomes political. It becomes a problem. And we work our way through it. Waitlist priorities and throughput. Waitlists are a huge problem in most places. How do we get people through? And of course, the pandemic has made surgical waitlist even worse, much worse. We're talking about getting years just to catch up in Canada. Overtime and undertime. You've got the operating room for 8 hours, which means you've got nurses for 8 hours. You've got a team for 8 hours, but the doctors have booked patients in. And the surgeries they're not deterministic. There's all kinds of things that can happen in terms of the length of time. There's estimated time. The doc estimates this is how long they think it's going to take. The actual time can be different. And then one of the things that, when I was doing my simulation modeling for hospitals, I said, well, if you get to the end of the day and, how long does that next surgery have to go before you cancel it? If the surgery is going to go too late, we don't start it at the end of the day. And they'll look at me and they'll say, well, it depends, right? It's very difficult to tie them down to specific rules about when they cancel things and when they do things. Potential solutions, well, for the actual versus the estimated surgical times, there's been a lot of work on, historical evaluation of surgery times, in particular for a specific doctor doing a specific surgery. They said this surgery is going to take this long. We can measure that statistically. We can actually tell the doctors will occasionally, they will underestimate the amount of time. If they say they've got 4 surgeries that are going to take 2 hours, they actually take 2.5 hours. They might be allowed to do that last surgery even though it runs late. And some doctors do that regularly. Okay, so we can use statistical methods to verify that the doctor's list that comes in, is that something that we can actually do in 8 hours? What's the probability of being able to finish on time? And then a lot of simulation modeling. So we've actually done some generic simulation modeling. We've created a generic model. We've used it in 15 different hospitals to help them design their master surgical schedule. And as an example, one hospital, and it's sort of fascinating, we designed this to help them build their master surgical schedule so that the hospitals could could balance the use of downstream resources and balance their wait list, looking beyond just the operating room. And it was fascinating. We had one hospital in Saskatchewan, and the Minister of Health in Saskatchewan back in 2011, and he announced that nobody was going to wait for surgery for more than 3 months by 2014, and over the next 3 years. And so one of the hospitals said, "Well, wait a minute. Our wait list right now, our average wait time for orthopedic surgery is 8 months. The 90th percentile was a year and a half. And how do you expect us to get that down to 3 months within 3 years?" So he said, "Well, if we're going to do that, we need a new orthopedic surgeon. Plus, we need more OR time. We need another OR." So the ministry looked at them and said, "Well, wait a minute, you guys just aren't being very efficient. You're not making good use of your time." And so we were brought in to go to the hospital to explain to them that they were, you can imagine how, back to my second slide about open mic night at the hospital, you can imagine how thrilled they were about that we were going to come in and explain to them how they weren't being efficient. So we used our surgical model, looking at average weekly throughput, and we used their current wait list and predicted arrivals. And one of the things that we discovered was that they were indeed being inefficient. They were not using their time appropriately. But we also did realize they were asking for $2 million. They needed the $2 million. They needed the orthopedic surgeon, et cetera. And we were able to demonstrate that using our model. But one of the things we discovered was that general surgery in particular, nobody was worried about that because it was only a 6-month wait list for 90%, but it had to get down to 3 months, and it was actually growing. It was getting worse. They also had serious bed capacity issues. And one of the things we were able to do in our simulation model, because elective surgery happens during the weekdays, on the weekends, the surgical beds would clear out. The medical patients were still flooding in. So medicine would steal beds from the surgery. And then on Monday, the surgeons would come in and they want the beds back, but they're full of medical patients. So I actually had to cancel surgery because the beds were full. There was one ward that had 32 beds in it. And we figured out by using our simulation model that the surgeons only needed 17. So we just said, "I'll tell you what, why don't you take 15 of those beds and give them to medicine? Keep 17 and protect them, ring fence them." And we demonstrated using simulation that they could do that without having to cancel any surgeries. They never could have figured that out on themselves, their own, without trial and error. So it was fascinating. So at the end, everybody was happy. But there was a time there I was a little worried. Waitlist management. In Canada, it's been a problem. We've been trying to control wait lists for forever, with some success. Then COVID came along, and now our wait lists have gone out the window. And so, looking at hip and knee replacement. So, hip and knee replacement, the wait list is kind of funny because what happens is a referral. You go to your family physician and you say, "I've got a problem with my knee." The family physician refers you to a surgeon, and the surgeon will look at you and examine you and decide if you need surgery or not, or maybe you just have rheumatism. Surgery isn't going to help. And so but it takes it takes months to get from the family physician. You sit on the wait list waiting to get an appointment with the surgeon. Then you get an appointment with the surgeon, and by some estimates, the surgeons are taking like 60% of patients will be referred on for surgery. But before you get referred on for surgery, you may go in and they have what they call prehab, or they call optimization. And optimization, there's functional optimization, which is looking at, for example, physio or weight loss. I'm not going to replace your knee until you lose 30 pounds. you're just going to, you're not going to be able to, you're not going to be able to adjust to it. And so they may do something like that, so that you may actually go through a program. There may be a medical optimization, insulin, cardiac. You're not ready for surgery yet until we get those things under control. And then once you get through that, then you go into a surgical booking system. And in the surgical booking system, then you wait for surgery. You wait for surgery time, go into the OR scheduling system. After you're scheduled, you have time in the hospital, and then you get discharged for home care. And there's lots of extensive rehab after that. Right. Scheduling challenges, well, each surgeon has their own wait list. There's no central wait list for surgery. So you get referred by your family doc to a particular person, to a specific person. Now, it's fascinating. So each surgeon has their own wait list. And in fact, surgeons like to have a long wait list. If you've got a long wait list, you must be good. If you got referred to somebody and they said, "Oh yeah, I can do you next week," would you worry? How come you've got such a short wait list, right? So long wait lists actually there's a perception that long wait lists are actually a quality metric. You're popular, you must be good, right? So there's a perception problem, a perception issue. And the surgeons, one of the big problems is surgeons are reluctant to schedule patients in advance. Remember that doctors, surgeons have a fixed amount of the service time they have is fixed because they got 2 days in the OR and for the next 6 months to a year. And so they've got only so many patients that they can do. But they know that they're going to get urgent or emergent patients that are going to take priority over the elective patients. And so they are very reluctant to give you, they say, yes, you're on the list for surgery. We'll call you when it's time to have your surgery. So, and it'll probably be 6 or 7 months. So you go home and you wait for the phone to ring, right? And every now and then you call up the office and say, where am I on the list? What's happening? And so you cancel your vacation plans. You cancel other plans because you don't want to miss that appointment in case you get a call. And the surgeons would like to call you up a week or two ahead. And it's just really, really frustrating. So one of the docs came to me and said, this is insane. We should be able to, I understand why the docs don't want to give them a specific time, but we should be able to give them a window. Right? We should be able to say, look, right now it's June, and your surgery will be in December, right? So you go ahead and have your vacation, etc. I'm not going to call you before December, and then in August or September, I'll call you up and say you're going to be the second 2 weeks, the middle 2 weeks of December, and then in November I'll call you up and say you're going to be a specific date, right? The thing is, and queuing theory for healthcare, for elective surgery, waitlist, queuing theory fails. And queuing theory fails because queuing theory assumes that the arrival rate, that the service rate is faster than the arrival rate. And we need that. And we need to be able to clear the queue. Well, in healthcare, we don't want to clear the queue. We don't want to have doctors sitting around with nobody to schedule in their OR. They're not going to make any money. They're fee for service. We want to make the best use of the time. So in fact, we want to make sure we maintain a bit of a queue. Now, the interesting thing is that the urgent and emergent patients can be modeled using queuing. So an emergent patient is somebody who shows up in the emergency department with a hip fracture. And if you don't do a surgery on a hip fracture within 48 hours, they will probably die. So it's very serious. So you just cancel everything to do that. But we can model those things, and urgent patients have to be done within a couple of weeks. And we can model those things using queuing. And so we start out with a list that's 6 months long. We've got a fixed number of OR times, and we can tell patients a range of possible surgical dates based on the urgent emergent list that we can model with queuing. Okay. We actually developed a pilot with a hospital, an orthopedic center in Winnipeg, Manitoba. They had 6 orthopedic surgeons. They had a central wait list. So when you go to this hospital, you get assigned to the surgeon with the shortest wait list. It was fascinating. I asked one fella in another city, not Winnipeg. I asked another fella, how come they didn't have central intake? He said, well, one of the docs in his group, he wouldn't bring his dog to. so the docs all have to trust each other, right? Their quality, the quality is kind of internal. It's funny. Anyway, we developed this pilot system using this model. We can predict a window for patients. And we were worried that the docs would give us pushback, but it turned out the main pushback came from the scheduling assistants because they had to do upfront work to figure out what this window was and then call people to tell them the window has been shrinking. They were worried about the extra workload. Now, mind you, they were getting dozens of calls every day from people who were, where am I on the wait list, et cetera. Those would all go away if patients had specific knowledge, right? That turned out to be a challenge. Diagnostic imaging. Diagnostic imaging is a huge problem. MRI, CT. In Canada, we've been trying to get control of medical wait lists starting around 2004 and set targets for everything. And things actually worked quite well for everything except MRI, CT. And it's just been chasing our tail for years. So magnetic resonance imaging. So here's an MRI machine, and it has magnets that spin around the donut. You're in the machine for 20 minutes, 40 minutes, etc., lying perfectly still. Good luck with that. We have priority levels P1 up to P4 for how long, and so we have targets for how long you should wait. It's divided by body parts. So there's head and neck, there's spine, pelvis, chest, extremities, etc., cardiac. Right? And now each one of these have a wait list. Now the emergent ones, these are people who show up in the emergency department and need an MRI today. And the P1s and P2s, they get them. The P2s are people who are in the hospital. They're in the hospital now. They need an MRI. The P3s and P4s are the problem. Okay. The challenges, well, first of all, the family doctor who orders the test will pick a hospital. So when I get an MRI, I get referred to this specific hospital. And the docs really don't know what estimated wait times are. We're actually getting better at that. They could. But typically they have referral patterns. So each hospital has widely different wait times. There's a significant number of inappropriate requests. You go to your family doc, you say, gee, I've had these headaches. I get these headaches for months. Well, maybe it's a tumor. So we'll do an MRI and see how that works out. Right? There's also a high no-show rate, and partly because our wait times are 4 or 5 months in advance, and our systems are when we schedule somebody for an MRI, many of the hospitals will send them something by snail mail. Your appointment is such and such a time. They don't ask them when they're available. They just send them a letter, and hopefully the patient actually gets it. We're starting to get to the point where some hospitals are actually being a little more, like I said, 30 years behind service industries. We're starting to get to the point where they'll actually call people up and remind them, you have an appointment next week, but that's rare. So there's a high no-show rate, like in the order of 15%. The scan times are 20 minutes to an hour, and they're booked by body part, they're grouped, and there's just a lot of difficulty meeting wait time targets. Some of the potential solutions. So central intake, and some places have, in Toronto, there are a group of 5 hospitals that have all got central intake. So you don't refer to a hospital, you refer to this group, and they will balance wait times across the 5 different sites and about 15 different machines. Oh yeah, one of the problems with waitlists that I forgot to mention, one of the problems with waitlists is is something called supply-driven demand. And so in Ontario, well, we needed more machines. Well, when we put more machines in, what happened was the demand went up. You know, if you can reduce the time a little bit, more GPs will order it if there's more availability. So in fact, demand has been increasing much faster than either the population or the supply. So it's been a real issue. Okay. So central intake, well, first of all, somebody can assess it for appropriateness on central intake. Advice on allocation to the hospital. So if you get in central intake, you know, you'd like to go to your closest hospital. But if you go to this other one, you can be seen 3 weeks earlier. Would you like to go to this other one that's a little farther away? Right? Involves, patient preference. How long do they want to travel to reduce travel time? We did one study where we decided that if even as little as 10% of patients are willing to go to the place with a shorter wait time, we can balance wait times across the hospital. We did that experimentally and using empirical data, not theoretical. Published guidelines on appropriateness. The appropriateness is not well understood among family physicians. And a lot of hospitals, if the family physician orders it, they'll do it. Nobody's really pushing back. E-booking systems with updates, reminders, and confirmation, that's starting to happen, depending on where we are. And Jonathan Patrick, several years ago, came up with, he had an approximate dynamic programming model he was looking at CT, similar to MRI. And he came up with a simple heuristic that actually he was able to show was very close to optimal. And the heuristic was intuitively strange. What it said, we've got P1, P2, P3, and P4. And so if a patient is P2, P3, P4, what you do is you book them into the last available slot within their target. So if it's a P4, you go out 28 days. And then you look for a time on day 28. If there's nothing, you go to 27, 26, 25, work your way back. For P3, you go out 10 days and work your way back, right? And P1, you do in the earliest possible slot. And if there's no time available for a thing, you just work overtime. There's no point in pushing it off to the next period. You're just going to make things worse, right? Now, the basic assumption here is that your arrival rate, your service rates are equal. That you're working a little bit of overtime to save yourself trouble in the next period. With MRI, as I said, the arrival rate is actually faster than the service rate. Wait times are growing. Blah. This is going to be a challenge for next year. But that was sort of a fascinating solution. As I said, Ontario wait time, MRI wait times, P1 and P2 are doing very well. P3, the target for P3 is 10 days for priority 3. The current average is 15 days. The 90th percentile is a lot bigger than that. 90% of people are waiting a lot longer than 10 days. And the target for P4 is 28 days. The current average is 55. The 90th percentile is well over 100. So people are waiting a long time. We're nowhere near P4. And no matter, I'm still trying to, I'm working with several of the hospitals to try to help improve this. But they actually have to change the way they do things. It's not just a scheduling problem. And I'm going to, shall I quit there, Mike? You're on mute. Oh, Mike, you're on mute.
I hear you well. You can follow.
Okay, sure. All right. So ambulatory clinic scheduling. So master clinic scheduling. So typically ambulatory clinics We've done this in several hospitals. And so this is looking at a hospital ambulatory site. They'll have multiple clinics going on, and doctors get assigned to regular clinic times in shared space. Each doctor has preferred days or times. Each doctor has unavailability. They're not available at other times. And so when they're doing a clinic, a doctor will have a particular cancer clinic, on Monday mornings or on Wednesday afternoons. And some of the rooms have special equipment. Most of the rooms are identical. Large number of rooms available. Some clinics use ancillary facilities. So for example, cancer hospital clinics, some of the clinics require blood work before the appointment. Some of the scheduling challenges, well, nobody wants to have their clinic regularly on Friday afternoon. Mondays are also less popular because of statutory holidays. If you have a Monday clinic, that means every time there's a Monday holiday, you lose your clinic day, right? And the doctors like lots of extra exam rooms. And what they do is they like to line up patients, have 4 rooms and patients lined up in each one. And then the doctor just goes bang, 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 comes around and circles back. The more rooms they have, the less likely they'll have where a patient is actually going to create a delay. The doctors also have a nurse and a fellow, et cetera, and they rotate together, collecting information, right? So there's a real challenge in terms of space, right? The patients have preferences. They'd like to have, they're going from multiple clinics, and they'd like to have them all on the same day. They don't have to come to the hospital 2 or 3 days. And there's congestion created by the schedule. So there's, the main cancer center, Princess Margaret, we looked at their clinic. And one of the problems they had is there are some clinics that require blood work, but they require blood work before your clinic appointment. So a whole pile of people, it would line up at 9 o'clock in the morning at phlebotomy to get blood taken. And so we had to spread out those clinics to try to spread out the workload in the phlebotomy labs. Some of the solutions, and all of these, it's fascinating, all of these can be handled as a straightforward interlinear programming problem. And we did this, and I'll show you an example. We did this, developed a solution method. The problem is that the initial solution is never feasible. That the docs want too many rooms, and the unavailabilities just don't match up, right? So you've got lots of rooms left over on Friday, but you haven't got enough rooms on Wednesday. So how do you modify the ILP? We want to provide hints for resolving the solution. I can't just say no feasible solution. So I have to do this like a goal programming thing. I have to even take the hard constraints and soften them and penalize them, et cetera. And of course, the hospitals have no clue what the weights are, so I have to make them up. So typically the solution is iterative. Women's College Hospital in Toronto, for example, and we published this. I can post this later. So they converted from inpatient ambulatory hospital in 2012. So this is the old hospital. See this old monster hospital. They stopped being an inpatient hospital. These were all inpatient rooms for the most part. And they actually tore it down and built a new hospital. And this is the new one. Now, 3 floors of this new one, of the new hospital, the first 3 floors were ambulatory rooms, examination rooms. And so what happened was, it was fascinating that the docs who were running clinics, because there were no inpatients anymore, the clinics just spread out like ants, like they were just all over the place. And so they had lots of space, and it was permanent. They could set up their clinic on the 7th floor and just leave all their stuff there. So when they had to move into a hoteling space and they had to restrict the number of rooms, they didn't even know how many rooms they were using or how many they needed. Nobody had a clue. We actually went through 11 iterations over 2 years, and it was all negotiation. Well, when we did that, you told us this were the rules, and this is the best we can do. And you got a problem. And so then they would go and talk to the docs, and then they would have this meeting and that meeting and come back and say, well, let's try this. Okay, we do it again. So we had 11 major iterations, and they implemented our solution completely, but it took 2 years. It was fascinating. And then finally, fracture clinic, and this is just a particular clinic, and scheduled versus urgent patients. The fracture clinic, And so what happens is people will show up, people get referred. You show up to an emergency department with a broken arm, they will put a splint on it and tell you to go see the fracture clinic on Monday morning. And they will just book you in. Some people need an x-ray prior to their appointment. There's simple patients and complex patients. Some ones are easy, some ones are just some of them are just review. There's orthopedic techs and orthopedic surgeons running in the clinic. Okay. And again, the doctors are fee for service, so they always want a patient ready. They don't want to wait. If they wait, they're not making money. Okay. There are lots of no-shows in fracture clinics. There's wait time. Somebody shows up. The x-rays are typically done in another department. So the person shows up and say, well, go to x-ray, come back when you're finished. They'll go and wait. They could come back in an hour or two. We don't know, right? So there's a wait for it's a drop-in thing. Orthotechs apply and remove casts. That could take some time. So what docs like to do is they like to front load the schedule. So they double book early slots to make sure they have a patient available. Some clinics, and I did this with my daughter at one clinic, they told everybody to come at 8 a.m. They got a 4-hour clinic, and the place at 8 a.m. must have had 50 people in the waiting room. And it was all first come, first served. By noon, the place was emptied out. The docs just want to have somebody there. Don't want to take a chance, right? And so some of the solutions minimize uncertainty. Well, first of all, the scheduler should have known who needed x-rays and who didn't. They don't, typically. They need to schedule the x-rays. They need the equipment in-house. One of the things we did was we said, well, complex patients, we want to reduce variation in time. We want to minimize patient wait time. And so we want to minimize uncertainty. And one of the best ways to do that is to do the long ones, the complex patients at the end of the schedule. Well, the docs like to do the complex patients at the beginning when they're still fresh, right? Because they're the ones who are their hardest work. They're the ones you have to think harder about, right? So we optimize overbooking strategy. We do need overbooking strategy. We're going to have no-shows. We're going to have changes. Right? So we want to maximize surgeon utilization, minimize patient wait times, and we've done some work on this in several hospitals using simulation. Need to convince the surgeons that their utilization will not be adversely affected. This is all about convincing the docs that if we reduce the flow of patients, reduce patient wait time, we are not going to reduce their utilization. And just as an example, one of the clinics that we worked at, the hospital assumed that docs could see 2 patients every 15 minutes. So they had their booking system set up. So at 8 o'clock, they would book 2 patients for 8 o'clock, 2 for 8:15, 2 for 8:30, etc. But the clinic only went until noon. So when they got to noon, they had no slots left. So they would go back to 8 o'clock and put a third person 8 o'clock, third person 8:15, third person 8:30. And then they'd get down to 12 o'clock. And literally, they would go up and put a fourth person at 8 o'clock, etc. Well, the clinic always ran late. No surprise there, right? The booking system didn't allow for it, and you couldn't send people away. So it was just the clinic was always a disaster. And one of the things that this particular clinic also had a union rule, and the union rule said that you couldn't penalize an employee for being up to 15 minutes late. So if somebody showed up late in the morning, up to 15 minutes, it was okay. So the culture in the place was that everybody showed up. The staff showed up at 8:15. The clinic opened at 8. The staff showed up at 8:15. I'm going, you're kidding. And then they would all leave 15 minutes early. They're going like, wait a minute. Anyway, so it's a lot of healthcare is culture change and tricky things. There's a pile of other scheduling problems physicians haven't got to: physician scheduling, resident scheduling, home care routing, PSWs, nurses, primary, advanced access, etc. I haven't talked about. But I hope that this has given you some ideas about problems that there's just lots of problems. If you're willing to accept the fact that they often have political implications. Thank you.
Okay, so thank you, Mike. That was quite a long list of open problems. And now I would like to open discussion. I will let you to unmute yourself. Okay, so now everybody should be able to unmute himself or herself, and you can ask questions directly.
Hi, can I talk?
Please.
That was a great talk. Really, really interesting. These are great questions. So first, just a quick comment regarding your flexible nurses. So you talked at the beginning about having this pool of nurses that are flexible, that can work on anything. That's a place where queuing theory could be very useful.
Yes.
So that's something that queuing theory studies, the effect on the number of flexible nurses.
Absolutely, yeah.
Anyway, my question is not about that. My question is there a sense in healthcare of small jobs versus large jobs? So I do a lot of data center scheduling. Okay. And there, some of the jobs are very small, they're very quick, and others take a very long time or use a huge number of resources, okay? And I was always wondering, in healthcare, is there a notion of, this can be handled very quickly versus something else that's going to take many days or require many resources, many doctors and nurses? And is there a sense of splitting them up? Like in data centers, the common thing we do is an algorithm called SIDA, which, sends short jobs to one place and long jobs to another. Does that come up in healthcare?
Let me add to Moore's question before Michael is going to answer her question, because Moore alluded to the difference in the expectation of the processing times. Mm-hmm. I think that in healthcare, as much as in cloud computing and processing, the variance actually can play an even larger role than the expectation. And maybe a surgery that has a large variance, you may want to schedule it at a time that it's not going to interfere with any other surgeries. So when you answer Moore's question, don't answer it only based on the expectation. Tell me also what you do, how you take the variance into consideration.
Right. I mean, in part, absolutely. There are lots of surgeries or lots of things that are minutes, and lots of things where there's a long length of stay in hospital and heavy use of resources. I mean, I think the simplest thing, and partly to Michael's thing, is just my last example with the fracture clinic. That the complex patients, I would like to do them all last, because then I minimize the variance for everybody else in the middle. Like, and the same thing with the data problem. I mean, like, the big jobs, I want to do the big jobs overnight. When I've got lots of time, I don't want to do them during the day, because then nobody else can get anything done, right? So there is that aspect, but I'm trading that off against the docs who don't want to do all the hard stuff at the end of the shift, right? So it's definitely an issue. I mean, it's definitely definitely a balancing problem.
Okay.
Yeah.
Thank you.
Thank you.
Yeah. Any other question? So if not, I would like to ask you, is there any notion of urgency? So for example, some of the operations might be quite urgent, not only in the sense that there was a car accident and now it's urgent, but also in the sense that preparation for the operation was very long, many tests, and they may disappear if the operation is postponed. And some other operations maybe don't have this nature, and they are more like best effort traffic, so to say, in Morse terminology. Okay, so they can just be there to fill the space. Is there anything like that? Because if there is some important operation, you can hardly predict its processing time, right? So the normal behavior would be, I cannot have two important operations side by side, because nobody knows if they will happen. So it's better to have one important and some unimportant, which can be skipped in the worst case.
I mean, I mean, it's fascinating that when we look at operating room scheduling for doctors scheduling their surgeries, I mean, typically they will, like I said, they call them elective surgery. An elective surgery doesn't mean you have a choice. It means you have a choice about when, right?
Okay.
And what the doctors like to do is when, they're making an 8-hour block and they don't want to have a whole bunch of really tough things all on the same day. So they'll do one big one in the first operation and then do some little ones. So they'll sort of balance their workload over the day to try to spread things out, and also to minimize variation, etc. Like you're trying to finish in 8 hours. You don't want to have your last surgery canceled. So you have too much variability on a day, you're going to get killed. You're going to get canceled, right? So it's there is that balancing act, but it's unfortunately it's not the scheduler, it's the individual doc who's making those decisions for most hospitals, and it's fun. It's interesting.
Okay, more questions, please.
Can I ask a question?
Yes, please.
So first of all, Mike, thanks for the very interesting talk. Seems to me that one of the issues that is unique or almost unique to healthcare is the cost of the equipment. Some of this medical equipment, I was reading that an MRI machine costs something in the range of $270 million. And I'm sure there's other equipment that's perhaps even more expensive. So there seems to be an issue here of utilization and resource sharing.
Yes.
And I was wondering if anybody has, you didn't mention that problem today, but it seems that sometimes it's not necessarily economic for a hospital to own an MRI machine. Maybe they would share it, maybe they would lease it, some different. So has there been any work on that?
Like in one of our the Canadian American, I pick on the Americans for a minute. Michael, you can turn your speaker off. Pick on the Americans for a minute. So one of the jokes is in Canada, if you need an MRI, you can always go to Buffalo.
Uh-huh.
And so in Buffalo, they have more MRIs than they need. They have excess capacity, and they charge for it, and it's expensive. And so in Canada, what we're trying to do is we're trying to balance that. And like I said, this queuing problem, we're trying to keep the service and the arrival rates the same, which always leads us into problems. We don't want to have very expensive radiation machines or MRI machines or CT PET scanners sitting around with nothing to do, right? It's a real challenge trying to get just the right capacity. You're absolutely right. Like, it's a huge problem.
I mean, there would also be cooperative game issues, right? Like purchasing decisions made cooperatively. I'm just wondering if people have done research on these types of problems.
Oh, for sure. And you're right. I didn't mention it. But I will add that to my list of possible, research topics. Absolutely. And again, I think in a sense, it's like the nurse planning problem, where we're trying to plan, a year in advance how many nurses we're going to need, or we're planning a year in advance how many MRI machines we're going to. The Ontario in the province, a hospital doesn't buy an MRI. The province buys an MRI.
Oh, okay, that's a good example, right?
Yeah, and the province doesn't want to buy one because they're so expensive.
Right.
And so there are agencies who look at what is the demand, does the demand justify it, where does the demand justify it. So the planning problems for major expenses, or for building a hospital, for that matter, right? And then the politicians will get involved, but never mind.
Thanks.
Thank you.
Okay. Any question?
Yeah, I have a question, if that's all right. You mentioned for the MRI planning that patients usually are grouped by imaging site.
Yes.
Is that so? but on the other hand, you have emergency patients who need an MRI today. So it might now be that the imaging site that patient needs already was scheduled, and you're in another group now. I'm assuming this leads to setup times then, or why is this done? Is the question behind it. So setup times, I'm assuming.
Yes, they're grouped by the elective cases are grouped by body type because of setups. First of all, because of setups, and secondly, when you have a cardiac MRI, for example, you actually want the cardiologist to be present.
Mm-hmm.
So it's actually the cardiologist is only there on Tuesday and Thursday morning. So that's when we do the cardiac MRIs, and then part of it is set up. Depending on the machine, the setup could be more or less, but you're absolutely right. Like the emergency comes in, we don't care what's booked. Emergency case goes through. A lot of emergency departments will have their own MRI. And so there's no grouping, there's no nothing. We just do them whenever, depending on the size of the operation. But yes, no, the grouping is but for convenience, not necessity.
Thank you.
Thank you.
Thank you, Mike. So, are there any questions? I think it was long.
I have another question, if it's okay. Could you, Mike, could you talk about the emergency, the ER system in Canada? So I understand this is quite a famous system in Canada. In ER, people come to the ER and then they're triaged, there are different levels, and then they're trying to maintain some kind of tail latency guarantee. So basically like tail latency, what I call tail latency, like the tier 1 must be handled within 15 seconds and tier 2 must be handled within 1 minute or something like that.
So there's the Canadian Triage and Acuity Score, the CTAS. We actually stole it from the Australians.
Okay.
It goes from 1 to 5. I mean, US has a similar one. The CTAS is interesting because it's strictly based on how long we think people can wait to be served.
Mm-hmm.
There's nothing to do with what happens after they get into the emergency department. It's all about their wait time. And so CTAS 1 is somebody who needs resuscitation. So they're not breathing. They have to get in right away. And then CTAS 5 is we call them the runny noses, right? And everybody in the waiting room in the emergency department is a CTAS 3. Right. So CTAS 2 is a heart attack. And CTAS 3 is pretty much everybody else. And then there's the 4s and 5s. The parents of kids, they don't know if it's serious or not. And there are targets. The targets we actually stole. We all steal from everything. We stole from the UK. So the UK came up with a 4-hour wait time. We want to get people in and out of the emergency department in 4 hours. And so in Ontario and Canada generally, we said, all right. So it's interesting that the lower acuity levels, so the 3s, 4s, and 5s, those people are going to be discharged. So we said those people should be in and out in 4 hours, and that's the target. The ones that are more serious are probably there for longer. We have to get MRIs, we have to get tests, we have to do other things. So that has a target of 8 hours. So we have a 4-hour and an 8-hour length of stay in the emergency department. And the government decided in Ontario in particular that they said, all right, what we're going to do is we're going to measure how many people got out in 4 hours. And if you can improve that, we'll give you extra money. But we'll actually give you the money up front to make improvements so you can improve it. If you don't improve it, we'll take the money back. So it was an incentive, right? And so it's called pay for results, P for R. And so it's a fascinating approach that it's but those are the 4 and the 8-hour targets, right? And it's funny too, like again, picking on the Americans, and you drive through Detroit, and if you're not seen within 30 minutes at our emergency department, it's free, right? Or you get tickets to the Detroit Tigers or something. I've seen those signs, right? And of course they're competing for business, right? And in Canada, and they publish wait times, at different hospitals. In Canada, it's a bit different because, in fact, the emergency departments would rather you go to another hospital. So they're not competing for business at all.
But how do you manage staffing to ensure these kinds of guarantees? That's the part that I don't understand.
Yeah, absolutely. I mean, and like one of the things that we're involved in, we have, again, we've developed one of my PhD students, and first thing is just coming out in winter sim now, but we've developed a generic emergency department simulation model, and so it says if when do you need extra nurses? How many beds do you need? How do you do ambulance offloads, and how do you handle them? And so we've worked with several hospitals to try to, how are you going to allocate resources in order to do this? How much is it going to cost? And is it worth it? What shifts do you need for the docs, for the nurses? The docs are actually more flexible than the nurses. You can ask the docs to come in an hour early or an hour later. And because they're basically fee for service, they're happy to do it. The nurses are, like I said, the schedules are set up months in advance.
Thank you.
It's a tricky problem, right? And because we are, and I think the image too, and I think this is true in mostly in Europe, is that because we're operating at this service rate, supply rate, arrival rate, trying to keep them balanced, keep a bit of a wait list, because you don't want to have expensive resources doing nothing, but you also don't want to have long wait times. And it's a constant, it never works. And of course, then COVID comes along and screws up everything.
Mike, we have one more question from YouTube. So I will read it. It's copied in chat. It's a question by Edgar Duarte. Many of those problems are related to indoor management. How to deal with more than one facility? Are there some experiences with linking facility location problems and scheduling in healthcare?
Absolutely. No, I think I mentioned briefly about central intake. So for example, for orthopedic surgery in Toronto, in the city of Toronto, there are 36 hospitals in the Toronto, Greater Toronto area, and most of them do orthopedic surgery. And there is one central intake center. You call in, you're still referred to a specific surgeon, but then they will tell you, by the way, if you go to this other place, you can get in quicker, etc. So central intake is huge. I think that's a big opportunity, and we're working on that too. Okay. I also only work on problems because because I've been trying to convince healthcare that they can use quantitative tools. I didn't come up with a problem. I went out to people and said, "What are your problems?" And they said, "Here, work on this, Mike." Okay, I'll get a student. Mm-hmm. So all of my problems are kind of reactive, which in some cases is kind of annoying, but never mind.
Oh, it makes sense.
Yeah.
We all will become patients one day, so we will.
Well, I just had minor, very early stage lung cancer treatment this back in February. They took out a chunk of my lung, and I'm now good to go. But yes, we all become patients eventually. And I'm glad to say that the hospital I went to was really efficient, and I credit some of my former students for actually doing that. Never mind.
Okay. It's a nice reward to see your students. Thank you.
It is. All right. And I'm more than happy to, if anybody has any follow-up questions, please, send me email, and I will follow up with some references shortly.
Okay. Thank you very much. So if there are no more questions, I will close the session. And I should tell you that in 2 weeks, we will have another talk by Andrea Scherf, and this is about educational timetabling. Okay.
I'm here. So.
Hi, Andrea. So are you ready? Are you ready to speak in 2 weeks?
No, I'm not ready, but in 2 weeks I will be ready.
Okay. So tough 2 weeks. Okay. Thank you very much, and see you in 14 days. Okay. Bye-bye.
Bye.
Thank you.
Bye-bye.